series of webinars on the essential public health functions. We are going to have a great session this morning for you. We're going to wait a couple of minutes so that a couple of our participants can come into the room. And so we will commence the session in 1 or 2 more minutes time. So we will be back with you in 60 to 120 seconds. Thank you. So a very good morning and welcome to you all. My name is James Fitzgerald. I'm the Director of the Department of Health Systems and Services here at the Pan American Health Organization. And we are really happy to have you all join us this morning for the first webinar on the Essential Public Health Functions series. This is a series that the organization has organized to really begin to re-examine and expand our vision of public health to really based on strengthening health systems and improving public health throughout the Americas. I wanted to begin by thanking all of you, our regional public health community, for being present here this morning. And I particularly wanted to thank some of our national health authorities who we have with us here this morning for taking the time to participate in this session. I wanted to recognize the Minister of Health of Argentina, Dr. Carla Visotti, the Vice Minister of Health from El Salvador, Carlos Alvarenga, and the ex-Minister for Health and the advisor to the Minister of Health in Peru, Dr. Fernando Carbone. In addition, we have health authorities connected from many of the countries throughout the region, far too many, unfortunately, to name here, but we want to really recognize and thank you for your participation here this morning. Our webinar today will have 3 guest speakers. We will start with a presentation from PAHO, facilitated by Natalia Houghton, who is our specialist on health systems and services analysis and monitoring and evaluation. Afterwards, we will hear from Theodora Swift-Kohler, who is a senior technician advisor on equality at WHO. And we're really pleased also to have Federico Guanais, who's the deputy head of the health division at the OECD. We'll then transition into a 30-minute question and answer session that I will moderate. Please note that during this time, you can submit your questions at any point via the chat. And at the end of the webinar, we'll receive some final remarks from Ernesto Bascolo, who is our advisor on health policy and who is leading the work here on the essential public health functions under the supervision and guidance of Dr. Amalia de Riego, who is our unit chief for access and services within the department. A couple of logistics notes. Please note that we have translation in English and Spanish, and we have international sign available for you. So please choose the appropriate language for your convenience. We're really also happy to have with us this morning Dr. Jarvis Barbosa, the Assistant Director here at the Pan American Health Organization. And I will hand over now to Jarvis for his opening remarks. Dr. Barbosa?
Thank you, James. Buenos dias a todas e todos. Antes de
Good morning
começar,
to all of you. And before I begin, I'd like to thank on behalf of PAHO for joining this webinar. It's a privilege for the organization to join this group of outstanding panelists and participants to exchange visions and experience on diverse aspects met by the health systems to reach universal health. This is the beginning of a cycle of webinars on the new version of the essential functions of public health, which PAHO has prepared with a group of experts in public health in the region and several health ministries of member states who have also participated in the development of this. These will be monthly sessions that will allow us to deepen into the different aspects of policies and tools related to conceptual and practical issues related to strengthening essential public health functions in the Americas. At the end of today's session, we will share the calendar of the next events as well as the website where you can access the materials for each one of the webinars. On 7th of April last, we celebrated the World Health Day under the consignment of building a fairer, more equitable, and healthier world after COVID-19. We're living difficult times, times of pain because of those who've left us, who have suffered the COVID-19 pandemic, but times of a lot of learning as well. We've had learnings that from 2020 where we've learned that to deal with the pandemic and to respond to its consequences mean to raise our eyes to the world of universal health, strengthening health systems from the essential public health functions and overcoming the inequities and barriers that the most vulnerable populations face to exercise their right to health. In the end, we're talking about the topic of this first seminar. The universal health approach has been reaffirmed by PAHO since 2014. And after a lengthy consultation process, the Executive Council of PAHO approved the strategy of universal access and coverage of health. Member states recognized that some of the main challenges meant that we had to emphasize the need to ensure access and therefore eliminate barriers faced by the population to access health services when needed. This is very important, particularly for some of the most vulnerable groups, such as Afro descendants, indigenous populations, poor populations of the periphery of some of the larger cities in Latin America. Some believe that about a third of the America's population is facing barriers in seeking health care, with a greater proportion amongst the poorest, while 23.7% of the people with higher income have barriers. The people with lower income find barriers in seeking for health services at about 31%, 31.5%. The result of this lack of access, just to give you an idea of the size of the problem, about 1.7 million deaths could have been avoided in 2016 in our region had there been accessible and quality services. This is twice the number of deaths reported for COVID-19 in the Americas in 2020. As you can see, the existence of these barriers and lack of access places at risk all the progress achieved by the region in universal access and universal coverage in health to ensure full access to comprehensive health care, appropriate, timely, and quality services is fundamental for human development. Countries of the region have agreed to follow this strategy and have started to apply strategic lines adapted to the context and the characteristics of each country. The region counts on a roadmap and a greater evaluation of health as a right, but the greatest challenge requires a multi-sectoral approach with different decision levels and influence levels, reaching the highest levels of government. The greatest challenge is to advance with the reform processes and transformations of health systems, clearly making right to health explicit, overcoming fragmentation and segmentation, and approaching inequities and social determinants in health. The solutions to our main problems can be found closer than we think. In this case, at the first level of care. Primary health care has been reaffirmed in the Astana Declaration 2018 as the key strategy to achieve universal health. But all efforts to transform health systems in the region to a new model of care based on primary health care have been limited. And that means that there are still barriers to access, as mentioned. And what's worse, in certain contexts, these barriers are multiplying. That's why in 2019, we assigned this work of universal health for the 21st century, 40 years after Alma-Ata, with a series of recommendations that member countries have assumed as their own and turned into a call for action, a step for primary health care for universal health. The Pact 30-30-30 of primary health care for universal health, assumed by PAHO that same year, attempts to speed up efforts in the region to achieve universal health and the SDGs in 2030, and asks for a transformation of health systems and concert efforts to eliminate barriers to access in a 30% as a minimum, investing at least 30% of the budget assigned to health at the first level of care. Eliminating barriers to access and to health services is a prerequisite to achieve universal health and the sustainable development of goals. But this requires a committed activity countries must deal with and support the largest number of strategic partners to invest in the essential public health functions, promoting intersectorial actions, strengthening governance in health systems, increase commitment and participation of persons and communities in the process, review the traditional forms of developing policies and planning health, changing the way we think of these barriers that prevent access and the exercise of their right to health. The essential public health functions, the renewed functions, are established to serve as a roadmap precisely to strengthen health systems and advance towards universal health with equity. To tackle the inequities and eliminate barriers with this roadmap will be fundamental to strengthen the preparation capacities, access, and responses to health emergencies, which we'll sure face in the future. PAHO has assumed this commitment by member states with the Primary Health Care Pact gearing its technical cooperation capacities to deal with the barriers to access to health services. To change the way we think about these barriers means that we have to advance towards a systematic characterization of dimensions and types of barriers. We cannot overcome what we don't know. We have to understand how they manifest in the different territories and how they affect differently depending on age, sex, and prior health conditions, and particularly how it affects the most vulnerable population groups, indigenous groups, the originary groups, the Afro-descendants, girls, boys, adolescents, women, LGBT persons, and amongst others. And it also implies to encourage us to have a design of policies that takes into consideration inequities and limitations to the right to health generated by these barriers. taking advantage of the knowledge accrued in recent years by several colleagues who are with us here in this seminar today. We have explored available methodologies and developed an analytical tool that rescues the contributions of important authors and the experiences of barrier reports of WHO. We've investigated different tools that are not the classical ones to consider the investigation of health, like household surveys, which gives us information and allows us to monitor the evolution of how we experience these barriers in the different countries and territories throughout time. And we've started to support those countries to have a better understanding of the many barriers that the most vulnerable groups are facing, like the indigenous people in the region, in Condorcanqui in Peru, or the children, boys, girls, and women in Honduras, or the populations of Interland in Guyana. In a few minutes, we will be sharing these in greater detail with all of you. We hope that this will be one further contribution to increase our evidence and knowledge about this problem, to be able to improve the tools continuously to monitor, measure, and characterize barriers to access. This is the first call to action, which we believe is important to share, increasing our evidence and knowledge of how the most vulnerable people are suffering the barriers of access to health. Equity, solidarity, and the right to health must be pillars of the health systems and must structure the tools with which we evaluate progress. The pandemic has affected the people in the region unequally, and these values must be present today more than ever. Our call to action to the decision makers to consider the greatest equity challenges left by the COVID-19 pandemic and the potential that comprehensive transformation of health systems will have to have a better approach to moments like these. And finally, to consider the evidence and the analysis of barriers in the design of policies, sectoral as well as intersectoral. This is fundamental. We must have evidence like these to implement policies to eliminate these barriers geographically, financially, organizational, or cultural. The essential public health functions, these renewed functions are an excellent roadmap for the design of these policies. Let's make these health policies in the post-COVID-19 era to bring us closer to ensure the right to health for all, to reach universal health. As our director often says, Dr. Carissa Etienne, let's make universal really mean universal. I leave you with these ideas, but the wealth of this activity will be in the contributions and experiences that we'll hear from our guests. I wish you a successful session and productive. And I thank you, the ministers, former ministers, vice ministers, health minister officers, our colleagues from the country offices, and our colleagues locally, who will be sharing their experiences to strengthen this movement, which is so important for us to effectively achieve universal health in the region. And I want to congratulate all of those who have participated in the development, not only of this webinar, but of this effort to renew the initiative of the public health functions in our systems, health systems and services department. Thank you all very much, and a successful and productive webinar. Thank you.
Thank you very much, Dr. Barbosa, for those very motivating remarks. I think Dr. Barbosa has really presented for us the clear linkages that exist between our quest for universal access to health and universal health coverage based on the primary healthcare strategy, the importance of strengthening the essential public health functions as a core component in leadership and governance within that context, and then the challenges we face really in addressing the access barriers within health systems. And that's a nice segue now into our presentation on access barriers that hinder the achievement of universal health in the Americas. Our presenter is Natalia Houghton, our colleague and specialist in health systems and services analysis, monitoring and evaluation within the Department of Health Systems and Services, and specifically within the unit on
Sistemas de salud en la unidad de acceso a los servicios. Natalia tiene una larga carrera en el apoyo a proyectos de investigación cual y cuantitativos de equidad en salud materno-infantil y prevención y control de enfermedades infecciosas. Tiene una maestría en salud mundial en la Universidad de Georgetown y su papel en el departamento actualmente es apoyar el análisis de la barrera de acceso en los Estados miembros de la OPS. Natalia, tiene usted la palabra.
Thank you, James. And I'm sorry, gracias, James. Y buenos días a todos y todas.
Thank you, James, and good day to all of you. And before I begin, I'd like to thank the interprogrammatic team for their support, who helped in this presentation and the work of access barriers in the organization. I would like to begin my presentation with two messages I believe are key. The first is that the analysis of these access barriers should be a holistic process. It should include the use of different tools and an analytical frameworks. And Theodora will talk to us about that in greater detail in her presentation, and also the use of different sources of information, such as quantitative data, household surveys, administrative data, as well as qualitative data. The qualitative data are very important because these are the ones that allows us to contextualize the information we're analyzing, as well as understand the intersectionality between the different barriers to access in greater detail faced by the different groups of population. The analysis of barriers also includes monitoring tracer indicators that will allow us to have a better idea of the progress achieved by countries in reducing and eliminating the access barriers progressively. The second message that I find is very important is that the analysis of these access barriers is a process which is possible. It's feasible, in fact, to do this type of analysis. And in fact, there are many countries in the region that are currently carrying out different studies to try to understand what are these different access barriers. And the best example for us are the studies that try to see what the situation of women is in the rural areas in Honduras or Guyana, and the situation of migrant women, as well as the situation of indigenous populations in the Peruvian Amazon. And also in the difficult context of this pandemic, it also includes monitoring metrics that explain continuity in the access to services, continuity services. It might be important also that we consider the current situation, the degree or the size of this problem of access barriers. And in this respect, the household reviews and the tracer indicators like the unsatisfied needs in health give us a general idea of the size of the problem. In fact, what surveys tell us is that about 3 out of every 10 people in the Americas do not seek for the healthcare needed. And in fact, when we compare that panorama amongst the different groups of countries in the region, we realize that the situation is even worse in the medium to low income countries, where 44% of the population does not seek for healthcare when needed, compared to the countries with high income, where it's only 12%. Now, not to seek for the healthcare has important implications. In fact, it increases the risk of mortality and morbidity, which could be avoided if they had timely access to the health services. In fact, when we try to cross both variables, avoidable mortality, as well as the percentage of the population that does not seek for the healthcare, we realize that there is a relationship between these. We see on this chart, for example, that the countries that tend to have a high number of people who do not seek for the healthcare in a timely manner, they also suffer high avoidable mortality rates. And those countries that are in the high income levels, probably the population, the percentage of the population that does not seek for health is very low, and so is the avoidable mortality rate, which tells us several things. For example, the need to improve the timely seek for information to have a positive effect on the mortality rates. But it also shows us how important it is to monitor this type of metric, which in a way explains the health system's ability to improve the access conditions. And even better, it would be to have an idea of the reasons why people do not seek for this healthcare. What barriers does the population face? And in this respect, the household surveys also give us a very interesting overview explaining the situation in some of the countries of the region. In fact, we realize two things which I think are very important. The first is that the barriers to access are multiple. There are many reasons why the people, in fact, do not seek healthcare in a timely manner. And secondly, that experience of the access barriers changes depending on the context of each country. And this can be seen on this chart where we see, for example, the high income countries and realize that a large number of the people suffer barriers of an organizational or administrative type, as they call them. These barriers are things like high waiting times, inadequate schedulings, or administrative processes in the search for attention, which is complicated for people. However, if we pass to the countries of medium to low income, we see that this is slightly different.
And in fact, in this group of countries, we're talking about barriers that are based on unavailability of resources such as human resources, medication, and other essential items for healthcare systems. And this is what represents the highest degree of issues in access to healthcare. We also have other barriers such as geographic barriers and acceptability barriers. This acceptability issue is important because it includes linguistic barriers that affect different population groups and doesn't address the ill treatment that they could be subjected to in the healthcare arena. In many cases, we see people that opt for traditional medicine, and these are causes and part of the reasons why people are not seeking timely healthcare services. So, what does the information tell us? Well, the information tells us that if we want to move the needle in a positive direction towards universal healthcare with equitable access, it's important that we develop policies to address each one of these barriers to access to service that affect different parts of the population. Another thing that's important is to understand that the context changes from one country to another, and the analysis of these policies in a more localized way will allow us to understand these differences in a much better way. Now, when we talk about equitable access, we need to understand that the barriers to access affect different populations in a different way. And this has led us to realize that the population that suffers the most poverty experiences these access barriers in a much more frequent way. And this covers the entire spectrum of lack of resources and acceptability and other issues. Now, if we were to add other factors, including socioeconomic factors, into this grouping of issues, then we could see different access barriers to with different types of women or groups of women, as well as men in different types of populations, such as indigenous populations, as well as other geographical barriers. So the idea is to not leave anyone behind, and this makes it a mandate for us to understand that we need a differentiated approach, and not just from the standpoint of analyzing these access barriers, but also other policies that seek to try to address some of these issues. Another crucial issue relates to social determinants for health. This is a subject that could encompass an entire presentation, but when we talk about gender barriers, we need to focus on the importance of this situation. If we take into consideration early marriage, which is prevalent in many countries in the Americas, we see that in and of itself, early marriage increases the risk of having poor sexual and reproductive health for young women and girls. But some of the studies that we've conducted with regard to gender issues have led us to understand that this group of women experience higher rates of barriers with regard to their autonomy. Much of it related to the fact that they entered into marriage or conjugal unions in a much earlier stage of their lives. And this permeates to their children. Now we need to focus on the difficult times that we're experiencing during COVID-19. We've been immersed in this pandemic for over a year, and many countries are reporting grave deficiencies in health services for the population. Almost 50% of the countries in the Americas reported interruptions in essential health services, primarily in terms of promotion and prevention efforts. There are multiple reasons that underline these. There are many barriers to access that I've already described in the presentation, but there are also new barriers that are a product of new social dynamics that have been caused by the COVID-19 pandemic. And this points to the fact that there are new challenges for health systems that makes it more difficult to address these different barriers to access. I just wanted to conclude my presentation with an invitation to have all of you to strengthen our functions of surveillance and evaluation, and we could systematically conduct the analysis for access barriers and include an assessment of public policies that seek to strengthen healthcare systems. Many countries in the region have information already available that would allow us to undertake this type of analysis. And as we strengthen our information systems, we can also start to include different types of information. As I was stating earlier, qualitative information, administrative data, addressing these from a mixed or integrated way that would allow us to have a better understanding of all of the factors that affect different populations under different conditions of health. And as part of the strategies that would be developed from this analysis, we could then provide better coverage for the various distinct affectations that affect different populations. Thank you very much.
An excellent presentation. I take three messages, I think, from the presentation that I think are very relevant for all our participants today. First of all, it is important to measure access barriers, and it is very possible to do it. Many of the countries are moving in this direction, and it's something I think that we need to advocate for, to be able to examine those differentiated inequities that persist within our systems. These inequities and access barriers exist between countries and within population groups, and our policies need to be guided accordingly to address them. And finally, we need an intersectoral approach, really looking across all sectors to address the barriers that are persistent. So with that, I'd like to move on to our next speaker, who is Theodore Swift-Kohler. She'll be presenting on global initiatives and experiences in the identification and addressing of access barriers, its application for the Americas. Ms. Kohler is the Senior Technical Advisor for Equity at the World Health Organization in Geneva. Her current role, she promotes universal health coverage and supports member states in the assessment of health barriers experienced by marginalized populations. In addition, Ms. Kohler serves as a member of the High-Level Committee on Programs and Equalities Task Team at the United Nations Sustainable Development Group, Leaving No One Behind, and Human Rights Team. And she also participates in several interagency platforms for the eradication of rural poverty. She's published over 50 works and holds a bachelor's and master's degree from Stanford University. So over to you, Theodora.
Thank you very much. I'd like to ask if everyone can please see my screen.
We can see it well, Theodora.
Okay, excellent. So it's really a pleasure to be with you all here today. And I want to start by just saying, really, why is it so essential for us to be looking at barriers to effective coverage with health services? And I want to underline that first, it's improving overarching health system performance. Second, it's for reducing health inequities. Third, it's for improving financial protection. Fourth, it's for enhancing responsiveness to non-medical needs and ensuring integrated patient-centered care. And fundamentally, it's about ensuring the right to health for everyone. In WHO's 13th General Program of Work, there's a very strong focus on barriers, and the program of work explicitly calls out the Secretariat to do more with regards to its support to member states to address barriers to health services, and also commits the organization to working on normative guidance to support member states in doing this. For the work that is now underway in WHO headquarters, we are using the Tanahashi framework for effective coverage, which has availability, accessibility, acceptability, contact, and effective coverage delineated. A coverage curve, it clearly delineates the target population who do not contact services. In the slides that follow, I will go through each of these dimensions in depth. But I want to start really by saying a bit more about what we mean by effective service coverage. And we're referring to it being defined as the proportion of people in need of services who receive services of sufficient quality to obtain potential health gains. And with this, we mean really that we're looking at things like diagnostic accuracy, we're looking at treatment adherence, we're looking at provider compliance, we're looking at effectiveness of referral systems. So it is not only just service coverage, but it really delves deeper into these quality dimensions. Now, in HQ, currently, we are working on a handbook for assessing barriers to health services. And this builds on 10 years of work of trying out barrier assessment methods in different country contexts, collaboration with the different regional offices. I'd like to say we are very much inspired and learning from the work that is now underway in PAHO, and have exchanged on various occasions with colleagues there to learn from what you all are doing. In addition, over the last years, we have commissioned some reviews, some lit reviews of methods to assess barriers. And the one I'm showing on this slide is particularly looking at findings from a lit review that we commissioned to Johns Hopkins University. And it looked at across 3,274 different articles. We did an analysis of the article abstracts, reviewing a total of 7,212 barriers. We looked at how different types of barriers were covered by the articles. And we saw that often the articles, which predominantly, I have to say, focused on RMN-CH and HIV, predominantly they looked at availability and acceptability type of barriers. There was less coverage of accessibility, affordability, utilization, and effective coverage. Effective coverage, which as stated before, is very important to really delve into the quality and that ensuring that patients are obtaining the full intended treatment. That dimension was not well covered at all by the articles that were reviewed. In addition, we see that there's a mix in methods, that very few of them actually used a mixed method approach, which we in our work would definitely advocate for, because quantitative and qualitative together can provide very important insights that when you use one alone, you cannot. By adding qualitative onto quantitative, you're able to understand more of the compounding and intersecting effects that different barriers can have. And that is really important to understand if you were to design effective interventions to overcome them. So just to go through the different dimensions of the Tanahashi framework that we use, under availability related barriers, we have insufficient number or density of health facilities, inadequate number of appropriately skilled health personnel, scarcity of necessary health products inputs, and shortage or poorly functioning basic amenities like electrification, water, and sanitation. Under accessibility related barriers, this is divided into 3 different domains. We have geographic transport related, covering issues such as distance, availability of transport, time for transportation, and time is actually a really key one to look at different geographical landscape barriers, road quality. And then also under transport related, we look at the autonomy in movement. And here I'd like to call out specifically a gender issue with regard to women and girls who may not have the same autonomy in movement without being accompanied by a male household member. Under accessibility, we also have financial related barriers, and that looks both at direct and indirect costs. Then we also have organizational and informational barriers, which relate to opening times, systems for scheduling appointments, administrative requirements like being registered in the local area, or for example, if you are a migrant who may not have the paperwork that is necessary to be able to access services in a given location. Information on the services in formats that are appropriate and that really reflect the cultural diversity and linguistic diversity of the population. And then also there are accessibility related barriers related to working in the informal economy, for example, not having paid sick leave to be able to go to an appointment. Some of the acceptability related barriers that Natalia has highlighted previously refer to culture beliefs about health and illness. They can also refer to the lack of connectivity integration between indigenous systems, traditional health systems, and conventional health systems. They also look at gender norms, roles, and relations that inhibit access, the age appropriateness of services, whether or not services are confidential. Perceptions of service quality can also inhibit people from seeking out care. And then also the safety of service delivery points, including not only in complex zones, but in locations, in neighborhoods where visiting those locations may pose different difficulties from a safety perspective, discriminatory attitudes by providers as well. And this can be based on sex, ethnicity, marital status, religion, disability, sexual orientation. And all of these together, they often compound and intersect, and we need to look at them using an intersectionality approach. With regard to contact coverage in the Tanahashi framework, this really refers to the actual coverage between the service provider and the user. And this happens when services are available, accessible, and acceptable. And the lack of contact coverage we consider to be the foregone care. Now, coming back to the final level in the framework, the Tanahashi framework, is effective coverage related barriers. Again, as I said before, looking at diagnostic accuracy, insufficient provider compliance, weak referral and back referral systems, and then inadequate treatment adherence, which is often due to the patient-provider relationship, a mismatch between the treatment prescribed and actually the capacity of the patient to adhere based on their living, their daily living and working conditions, adverse socioeconomic conditions that may continue to negatively influence the health condition and that aren't being adequately accounted for, and gender norms, roles, and relations. So just coming now, after reviewing the framework, I'm coming now to the handbook that we are working on here in headquarters. And it contains different modules that can really support a research team in carrying out a barriers assessment. We have the preparatory stage that very much looks at alignment with the policy programming cycles. It looks at an inception meeting for convening key stakeholders, including government, academia, civil society, other key players, also from other sectors when appropriate. And then, of course, doing the research plan with the ethical review clearance. Then we have key informant interviews, delving into supply side issues. We have a literature review to really make sure that the barriers assessment would build on and complement the existing evidence and not, let's say, duplicate efforts. And then we have the quantitative analysis, looking at different data sources, focus groups that delve into, let's say, a deeper understanding of the demand side dimensions and also their perceptions, the population's perceptions at different subnational locations of the supply side issues. And then we have the module 7 dedicated to the data triangulation across the different sources, and then really synthesizing the findings cohesively in reporting, and then taking it on to the workshop, which is aimed for not only dissemination, but really it's when we start moving towards the identification of entry points for change and acting on these different barriers. And the same stakeholders that have been involved across are convened again, possibly with additional players that are very important for different barriers that have been identified, to look at mapping out the way forward. Now, I'm going to take you quickly to Mongolia just to share in a snapshot an example of how we also used barriers assessment and the Tanahashi framework in mapping out barriers for a patient pathway. In particular, this you're seeing here, the patient pathway for treatment of cardiovascular disease in a rural and remote area. And you're seeing the participants all from subnational government come together and really look at, okay, drawing on aspects of the Tanahashi framework, what are the key barriers that emerge at different stages in the patient pathway? And then they looked at considering what could be done in the context of their 4-year plan. And here in the lower left-hand side of the screen, you're seeing the workshop agenda that we used with them for 3 days to really explore how to integrate barriers and a response to those barriers, research also to look at more with the feasibility of certain responses, how we could work that into their subnational 4-year plans for health system strengthening. And here also are just some summaries from different countries that we worked with on assessing barriers, some different summaries of the barriers that emerged for the rural poor in particular, and areas that we saw that there was a clear need for address in policies and programming. So just a final word on our global work. We are also expanding on how our methods unpack affordability related barriers. And here we're looking at how they can take a more systematic, we could take a more systematic approach for looking at, for example, population coverage with financial protection linked to eligibility, procedural issues in registration, renewal, lack of awareness of entitlements and issues regarding perceived quality of the benefit package, issues related to the depth and breadth of the benefit package, explicit health financing rationing instruments such as direct cost of premiums, formal and informal user fees, co-payments, deductibles, and then indirect costs, for example, with regard to transport and accommodation and other barriers. So just in terms of some resources available now online, over the course of the past years, we've, in working up to this cross-cutting global guidance that can be used in primary healthcare strengthening, in reforms towards universal access in UHC, we've been working on different thematic areas. One is on adolescent health services, and there is a guide now available online that really delineates the methods, and I encourage you to look at that, and then also to look at Innovate. Actually we collaborated quite a bit with countries in your region for the original production of this, but the Innovate approach has a whole module dedicated to Tanahashi and exploring barriers, including through lit reviews. So we encourage you also to look at that. Thank you very much, and it's really an honor to be with you discussing this, and thank you again to PAHO for their leadership in this area.
Thanks very much, Theodora, for a very informative presentation. A couple of key takeaways I see. Obviously, the wide variety of methodologies that are out there. The importance of not just looking at the issue of availability, acceptability, and affordability, but really drilling down and looking at the issue of effective coverage, which is critical. And the need for rigorous methods in application to really to be able to draw out the information and generate the evidence required in order to guide decision making within health systems. So thank you very much for that. We will now move on to our next speaker, who is Federico Guanais, the Deputy Head of the Health Division of the Organization for Economic Cooperation and Development. Dr. Guanais has worked in health development and public policy for more than 20 years. Currently, he supervises the technical work in the areas of health statistics, health systems performance, patient-reported outcomes and experiences of care, and primary care at the OECD. He is also engaged in providing scientific and policy guidance to countries in the pursuit of high-performing health systems. He's been published in several academic journals, having received Paper of the Year Award for a study on the integration of health and social care, published by the American Journal of Public Health in 2013. He holds a PhD in public administration with a focus on health policy from New York University. And he'll present for us here today on access barriers and experiences in primary healthcare in the region of Latin America and the Caribbean. Federico, it's a pleasure to have you. Over to you.
Thank you very much, James. It's quite impressive to see the convening power of PAHO. I mean, the leadership that you have with over 450 participants. And every time that I check the number keeps growing. So it would be my pleasure to share some of the reflections that I have today on this topic. Let me see if I can get my screen to share. All right. Can you confirm? Can you see my screen? Not yet. Maybe now.
Yes, we can see it now, Federico.
Okay. All right. So now let me just do this. So right, and I would like to thank Natalia for reaching out and then to bringing this topic and asking me to talk about access, and also from the perspective of the patient, right? From experiences. From the perspective of the users of healthcare. So, and when I went back to look at the data, it's interesting to see that when you ask the people, and this is based on a survey that the Commonwealth Fund has been conducting from several years in 11 high-income OECD countries. And when I was at the IDB, the Inter-American Development Bank, we replicated that same survey for 6 countries in Latin America and the Caribbean. So that's a strong focus on primary care. But I think that the interesting thing of this survey is that asking the users themselves about their experiences of healthcare. So when you ask the people about the last time when they needed, whether they could get a primary care appointment in the same or next day, about half of the people say that they could get an appointment. And what struck me was that the difference is not that large between Latin America and the Caribbean and the OECD countries on average. However, if you look closely, it does have an important equity gradient by level of education in Latin America and the Caribbean, which is a proxy for income. So you see it goes from 44% to 52% to 56% when you go across increasing levels of education. But so I think that there's the first message is that, well, that's right. I mean, the differences in access to actually get an appointment in primary care are not that high, but this hides the issue of equity that's mostly associated in the countries in Latin America and the Caribbean. But if you actually move the perspective to looking into financial barriers to healthcare, and then we see that the problem is even more complicated. here is a graph that shows the percentage of people who had a problem but did not see a doctor or skipped a test or treatment because of cost and had serious problems paying for healthcare, comparing Latin America and the OECD. And here the differences are much more striking. There's also a gradient by level of education and therefore as a proxy for income in both countries, but in both groups of countries. But it is much more important in the countries in Latin America and the Caribbean. When you see the problem of delayed or foregone care due to financial barriers are very, very important in the region. And if we move even one step further in terms of, okay, what's the kind of care, that access to healthcare that these people are having in both group of countries, we see that the problems are even more complex. Here is a graph that compares the percentage of people who had what we are calling person-centered primary healthcare. And that is a composite index that takes into consideration 4 elements. The first one is whether the person has a regular doctor or place of care that knows their medical history, that's easy to contact during regular office hours, and that helps to coordinate care. And here, there are a couple of important messages. You see that even in OECD countries, fewer than half of all the people who responded said that they have primary care within these 4 characteristics. But when you look into Latin America, that's even much lower, around 10% for those who have primary or secondary education, and around 20% for those who have higher education. So here's one important thing. Approximately half of the people say that they have access to an appointment, but it's basically what kind of appointment? Is an appointment to a place that they use regularly, that know their history, that helps them to coordinate care, all of the things that we've been talking so much about, the attributes of strong primary health care. And here, I think that what we have in times of COVID highlight the importance of these things even more strongly. Having a regular place of care is an indication of also of the trust that you may have within your healthcare providers. Whether they know your medical history, for example, in times of COVID, it's key to allow for the providers to know, well, who are my patients who have previous existing conditions? Who are my patients who should be prioritized, for example, for receiving vaccination? And also in terms of the communication, is it easy to contact the care providers in case of need? So, and I think this highlights the important point that we might be talking a lot about the access, we might be talking about barriers, but we also should be looking into from the perspective of the patient themselves. What is the experience that they have when they're actually accessing primary care? In times of COVID, these things become ever more important. And now, as if this was not enough, we see that the COVID-19 has renewed challenges for primary healthcare everywhere. So even if we look into the OECD countries alone, so what we saw is that with the COVID pandemic, there was a drastic reduction in the volume of primary health care consultations during the first wave. I mean, the graph that you see here is graph for the spring of 2020, the spring in the Northern Hemisphere, meaning compared to the spring of 2019. So you see that across OECD countries, up to 50% of consultations were reduced compared to the previous year. So, and this is creating such an important backlog that's going to necessarily be dealt in the future by primary care and by other levels of care. So we give a few examples. In France, the number of cancer diagnoses decreased by 35 to 50% in April 2020 compared to the year before. This means that a lot of the people who could have been detected very early with better prospects of treatment will probably have dire outcomes and prospects because their conditions have been detected much later on. Similarly, in the Netherlands, the number of cancer diagnoses decreased by 26%. So here is important that we already have important challenges in primary healthcare, and COVID made them even more apparent. And I'm sure that in Latin America and the Caribbean, a similar trend took place. So one thing that I keep telling, and actually I was talking to James the other day about this, is the issue that we do have a policy window that's open for the discussion of health investments in healthcare. And I think that the worst thing that can happen is that all of these investments goes towards to the things that perhaps are in lots of people's minds, which are the acute care, which are the intensive care units, which are only the treating patients in the last mile. Of course, it's important, and we recognize that the region has shortcomings in terms of the access to hospital beds and ICU beds. But who are the patients who are most likely to end up in hospitalization and with a severe case of COVID are precisely the ones who have a pre-existing condition, who have a risk factor such as obesity. So keeping a strong, resilient population also is a part of having a strong, resilient health system in the future. And here are the things that primary care can and should be doing during times of pandemic. So first of all, the continuity of care, taking care of people with the chronic conditions, help them take care of their conditions without interruptions that we see in continuing the vaccination and screening programs, community engagement, and so on. But during the acute phase of the pandemic, we saw very little discussion of what's the role that primary care could have in even the tracking and tracing of the COVID patients, caring for the mild COVID patients, following up after the hospitalized patients come back to the community, and promoting public health measures. Very often, primary care was not even equipped to do these things, for example, with access to enough tests and so on. And in the aftermath of the pandemic, we foresee really an important backlog of cases of patients who suffered the direct and indirect effects of COVID crisis. Those who had delayed and foregone care, those who have COVID and are suffering for long COVID, those who have mental health consequences of the pandemic. So here, I think it's time for renewed surveillance and care models that we can think of primary care in the future. And also moving forward, I would like to show this slide to close my presentation with a discussion of an initiative that we're conducting right now. So these are usually the aspects of the health systems that we're measuring, including the barriers. I mean, what's the characteristics of the delivery system? What are the individual and social demographic factors? What are the capabilities of the healthcare system? What are the health behaviors, and so on? But what is it that we're missing from this picture is the patient-reported experiences of care and the patient-reported outcomes of care. So there's no sense talking about whether the roles of primary care are being fulfilled unless we have information that's reported by the patients themselves, right? Even the classic Barbara Starfield characteristics of primary care of access, comprehensiveness, continuity, coordination, these are the things that we should be asking the patient themselves to report on these indicators. And also in terms of the patient-reported outcomes, we're maybe talking about hospitalization and death, severe outcomes, but how are people extracting or being able to have strong quality of life, function, lack of pain, self-reported health, and so on? What are the outcomes that really matter to the people? And that's why at the OECD, we are conducting now, we're working hard to put in place a new generation of health systems indicator. This that I'm showing there is the number of countries that have signed up to participate in what we're calling the PISA for healthcare. I'm sure many of you know the PISA, the Program for International Student Assessment, which is the OECD evaluation of educational systems. Now we're working to put together the Paris, which is going to be the patient-reported indicator surveys. Right now, we're piloting this experience in 20 countries. We have Spain, we have Portugal on board, so we're going to have questionnaires in Spanish and Portuguese, of course, English and French as well. So I think it would be a shame if we didn't have also this data for Latin America and the Caribbean. We're still working on that, we're still developing, but I would like just to plant the seed of this conversation that if we want to know what matters most in terms of the access and the outcomes that people are experiencing, we should ask the patients themselves. Thank you very much. I'll leave you here my contact details. Over to you, James. Thank you.
Excellent, Federico. Thank you for that excellent presentation. It's very interesting to see the parallel situation in OECD countries and all other countries in Latin America and the Caribbean with regard to the impact of the pandemic in access to essential health services, very similar trend. And of course, we note that the financial barrier is, if not the principal barrier, one of the principal barriers to access healthcare services in the region of the Americas, constituting up to 30 to 60% of health financing at this point in time. We also recognize, I think, as you very well pointed out, the importance of really zoning in on patient-centered care, people-centered care, and beginning to work with the person, with the patient on their needs and what their perceptions of quality integrated care is, and what the perception is in terms of access barriers. And this links in very well with then the discussions we were having on the need for more resilient health systems coming out of COVID-19. PAHO is preparing at this point a policy document for our member states on resilient health systems that is very much based on a primary healthcare approach to accelerate the recuperation of lost public health gains that we'll be presenting in the executive committee meeting in May. So thanks, Federico. I will now move on and ask my colleague, Ernesto Bascolo, who's the regional advisor on health governance, leadership, policy and planning at PAHO, to give us a few remarks. Ernesto is an economist with extensive public health and research history. He holds an MPH, a master's in health economics, and a doctorate in social science. He is responsible for the regional agenda of PAHO's technical cooperation in the measurement and strengthening of the essential public health functions in the Americas. So over to you, Ernesto.
Muchas gracias, James.
Thanks, James, and good morning to all of you. I'm going to take a few minutes to close this meeting and review maybe what I could call the key messages of what we have found this far in the presentations. And I'm going to divide them into three. The first part is to try to recover the current seminar, the first one within the framework of this series of essential public health functions webinar. And second, what were the main messages of the presentations themselves? And lastly, next steps of this set of activities. Well, we began this seminar framed in the new conceptual framework of essential public health functions. As Dr. Barbosa said, and in the Universal Health Strategy objectives, it's a context of extreme complexity due to the COVID-19 pandemic, its consequences in health and epidemiology, as well as economics and social. Today, more than ever, we have to expand and strengthen, and I think that was very clear, the knowledge and practice and competencies of public health, placing the essential public health functions in a strategic orientation, the leadership in health authorities involving, and this is an unavoidable mission, a collective action with scientific experts, technical teams from the health ministries, the health teams responsible for producing direct health interventions, and civil society, all the members and the organizations. As we see, many of these actors are with us here today, in fact, throughout the process and throughout these activities. Within the framework of the Universal Health Strategy, access to health services has been, today more than ever, a key dimension that wonders what the health system's response capacity is to deal with the health needs of the population. And it's in that respect and for that reason that we have to interpret to what extent our health systems can respond or adapt to those needs.
A las expectativas
and the expectations or cultural, social, and economic conditions of the population. It's like a bridge to interpret the relationships between the health system's performance and the actual health needs of the population. And what's more, the analysis of access and access barriers to health services, as said so clearly by the speakers, have a scope that actually goes beyond the performance of individual services. That's why it is so relevant in the essential public health functions agenda, because it has the potential to recognize the strengths as well as the limitations of the health system's capacities, particularly the leadership role of the health authorities to guarantee that the public health interventions deal in all contexts and in all communities with the risk factors, environmental health, and social determinants in health. We have to recognize that despite the progress achieved in the region, in all presentations, this was very clear. Despite the progress in recent decades of reform processes of health systems, when we review the barriers of access to health services, this continues to be a pending challenge. That's why measuring these barriers is critical, which should be done by all of us, particularly the health authorities, in the process of new policy formulation to respond to the real problems of the populations and in all the different contexts. Now, another message that was key has been a call to action. One of the fundamental elements is to change the way in which we think of these barriers of access to health services as an exercise that has to be part of the cycle of the policy formulation process, not just as a prior evaluation, but as an element that must go through all the different stages of the policy formulation cycle. Now, the initiatives that we're implementing in the organization, as has been said, are precisely with a view to support the countries in that activity, and the essential public health functions are an excellent guide for the roadmap that seeks to strengthen those critical capacities in the countries. The second aspect regarding the speakers, our guests have shared with us this morning a variety of elements, not just the conceptual approach, the methodological approach, but also very interesting results that serve to interpret the breadth of the problems related to these barriers and how they're manifested. And what do these actual barriers manifest when we interpret these indicators? And how do we translate that information into input in policy formulations? We saw the methodologic and conceptual framework used by the World Health Organization and also the Pan American Health Organization, in fact, reviewing the different types of barriers related to the Tanahashi frame. But also, Federico showed us a conceptual and analytic framework with indicators, dimensions, and control, which was very interesting, with several contact points like the rest of the organizations that are considering this theme. And I think there's a clear, open possibility for cooperation and joint work to strengthen this capacity in the countries. Our guests also spoke of the barriers from the point of view of concrete, particular reviews and analysis, something which is fundamental for us. We've had a chance to analyze the data in greater depth to first, and I apologize for reiterating, I don't believe that anyone has lost the fact that at least a third of the population is facing some type of barrier when it needs health services. And this is a very structural data, which also has a more significant weight, not only in the countries of medium to low and low income, but fundamentally through the greater vulnerability. And another important element, which has also been common to everyone, has to do with the first level of care, not only as an object of analysis to interpret the barriers, but as one of the fundamental lines for transformation of the health services. I don't want to go on, but we've heard very important concepts regarding the different types of barriers, the acceptability issue, the financial aspect, availability, geographic, organizational aspects. Each one is important, but the relationships between these is also important. And above all, the impact on the different contexts and the different territories and for the different social groups. Now, as I mentioned at the beginning, this is the first of a series of webinars, virtual webinars. This is one step more to expand the community of actors involved in the problem of public health. And I want to thank Theodora, Federico, and Natalia, particularly for their presentations. Very interesting, very rich in concepts as well as in data. And I believe that they really encourage us to continue this debate and to plan this roadmap to get further into this theme in aspects related to the essential public health functions. And I want to take advantage of this opportunity to tell you that we're going to continue with these activities practically every month from now until the end of the year. May 17th, we'll have the monitoring framework for universal health and the challenges and experiences related to the evaluation and monitoring function and the need to promote production and use of knowledge to serve the policy formulation services. And then there will be a series of other different topics, which in a way will be supporting the policy cycle of the conceptual framework of the essential public health functions, the legislation and policies, resilience, the financing of public goods to ensure the essential functions, human resources through an analysis of competencies which are necessary to make these essential functions effective, the risk factors in public health and environmental health, probably fundamental issue of these essential public health functions. And I can't mention also the weight of the social participation and the approach of the social determinants in health in all this. Well, I honestly believe that aside from the speakers, I want to take advantage of greeting and thanking not only the HSS team, but all the colleagues from the different departments who make these activities possible. And I want to thank the interpreters, of course, the speakers once again, and in particular, each and every one of you who are with us here today. Not only those who are with us here today, but those who have been following us with all the different activities that seek to strengthen the essential public health functions agenda as one that seeks to strengthen systems and improve the resilience in this complex context. Thank you very much. James?
Thank you very much, Ernesto, for that excellent summary. So we are almost coming to the end of this webinar. Unfortunately, we didn't have sufficient time to have a round of questions and answers. I think there was a lot of excellent information presented in the presentations. I think the words from our Assistant Director, Dr. Barbosa, really framed the discussion within the context of the transformation of health systems within the Americas towards the achievement of universal access to health and universal health coverage based on the primary healthcare approach, and having the essential public health functions as the core architecture to really strengthen public health capacities, so that we're having a more integrated approach as we strive to ensure universal access. At the same time, we are building the level of resiliency within our health systems. I too want to thank all the excellent presentations that we have received here today, from Natalia, from Theodora, from Federico, and of course the inputs from our own team. I think it's very clear that this must be a priority area of work in the region of the Americas if we're really going to generate the necessary evidence that we need to transform our health systems through evidence-based policymaking. If we don't have this information, if we don't have the data in the analysis of the barriers that exist within our health systems, well, then we cannot induce change. And it's that induction of change that we really need to promote as we strive forward in the transformation of our health systems. So I am urging all our participants to look into this in more detail. I'm inviting our member states and our countries to contact us, and we will work with you on the development of these methodologies at the national level through our country offices, and of course with our partners in WHO and the OECD as we move forward with this very important agenda. Dr. Etienne always talks about the need to leave no one behind. And if we're not going to leave anyone behind, we need to know what the barriers are that is impeding access to health within our health systems. And so this work is really a fundamental and core pillar moving forward. We've had over 500, we've had approximately 500 participants in this session today. We will have the session on YouTube. It's also being streamed live on YouTube. We have some questions that we will respond to in the chat on some specificities around the relationship between access barriers and types of health systems. Others relating to COVID-19 that I think were addressed in some way during the presentations. And the presentations, I believe, have been made available through the links for this meeting. Finally, before I close, I would like you all also to make sure that you register for the next webinar on essential public health functions. This is scheduled for May 17th, and it will be entitled Monitoring Universal Health in the Era of COVID-19, where we will delve a lot more into some of the issues around the impact of the pandemic on some of the elements that we really require to build health systems moving towards universal health. In particular, also looking at the impact of COVID-19 on what has happened in the provision of essential health services. With that, we will leave you. Many thanks again, and please join us once again on May 17th. Thank you very much.